finally call upon Dr. Mano Ranjan Das for a talk on techniques for successfully performing therapeutic penetrating keratoplasty in non-resolving corneal ulcers.
So good evening all of you. So after and at the outset I would like to thank the APO and AIOS committee to having accepted our IC for presentation here, and I would like to thank Naveen for giving me this opportunity to be part of AIOS. So after having discussion thoroughly about starting from definition of non-healing ulcer, the risk factors, what is precipitating the non-healing features, and second we went ahead with the madam's presentation about how do you manage the critical cases which is goes beyond your suspicion, and the third we went ahead with the along with the treatment for modalities of maximum medical therapy. We have gone for the adjuvant therapy starting until reaching up to the phototherapy, and next the madam nicely highlighted the role of the recent diagnostics to go for the management or next is main topic. So as you all know, the conventional treatment of any non-healing ulcer is surgery. So that is how we don't want, actually, because we know that surgery is not a great point to do. It has got its plus and minus also. So corneal opacity represents the fifth leading cause of blindness globally, and the recent WHO study says about 6 million population in the world around affected with the corneal blindness, and infectious keratitis is the main culprit of the blindness. The infectious keratitis is caused by a wide variety of organisms like bacteria, fungi, protozoa, viruses, etc. The higher incidence of infectious keratitis is attributable to poor environmental and personal hygiene, lower level of education and agriculture-based industries, work-related or trauma-related episodes, and the poor access to the sanitation and healthcare facilities. So by definition, therapeutic keratoplasty is a surgical procedure in which the part or the all of the damaged diseased cornea is replaced by a healthy corneal tissue with a primary aim to eliminate the infection load and to establish integrity of the globe. The secondary aim, of course, is the vision. So this is a therapeutic TPK microbial profile which is done by clinic profile picture. The study is done by LBP group, and this includes from 2016 to 2021 in the eastern part of the India, and they have found out over that 5 years they could have seen about 13,000 plus microbial keratitis, out of which 3,000 plus went for TPK, roughly about accounting about 23%. So this is how we have seen the profile, that the blue color represents the fungus, red color represents the no growth, and the bacteria represents the green color. The majority is chunk is responsibility is due to the fungal infection. We have got this spectrum of antifungals, but still the presentation of infectious keratitis can be varied way. We see them with a small stage, the small ulcer central, then it subsequently progresses to subtotal, and then total ulcer, then perforation, and then melt with uveal or lens prolapse. So that is already highlighted by Naveen that intrastromal voriconazole and Arjun had no offer, extra beneficial offer to give for non-healing fungal keratitis. This is one study which was done long back by our hospital, by showing that the collagen cross-linking therapy was also not helpful for deep stromal fungal infections. So this is a video. So if it is not helping us, then what will help us? So this is how we waited for the treatment, and this is a well centralized ulcer, the stromal abscess, so we had waited for all maximal therapy, so it went for a perforation with uveal. So for that point we could decide to go for a TPK, because we had a very healthy rim of more than 1 millimeter, so it was very helpful for us to secure the globe and restore the anatomical integrity. So this is how it will, after the end of the surgery, AC is well formed, and you can give intrastromal, intracameral voriconazole if you want, for all these cases when fungal ulcer is proven. So this is how it was day 5 post-op I discharged them, and you can see, because you use a optical grade tissue in this and the 3-month post-op, it looks really good. But all that affects you won't get in all cases. So how to improve the conventional outcomes of the TPK? So major thing for TPK is a good block. Whether you achieve it by the general anesthesia or local anesthesia, it is your choice. And another major component which hinders in the effective finishing of a TPK is the positive pressure management. So positive pressure management can be done by pre-op, starting with oral Diamox or acetozolamide, and then intra-op you can take the patient under IV mannitol. Subsequently, you feel the patient and have a touch for the eye and see that whether it is tight or hard at the globe. Then you can do a vitreous tap to decrease the ocular pressure. Of course, for large ulcers which needs better ream for suturing, you should do the peritomy and then start suturing after the surgery. So this is how few cases which is early detected can go for a therapeutic DALK. So therapeutic DALK is a noble procedure, but only thing is that it cannot be used for all type of ulcers, and you should be very specific, and you should have some adjuvant devices and to find out the depth of the ulcer. So here we have taken a non-receiving nocardial keratitis with about anterior restricting about anterior 2/3 of the cornea, and the depth was very nicely seen with the confocal microscopy. You can see we have seen that beaded filaments at here at about 88 microns, and here next is about 192 microns. Beyond that, it was all free. So we decided to go ahead with the therapeutic DALK, and this is how the procedure can be done. It was looking a wreath pattern, well circumscribed and central ulcer, so it was easy for us to delaminate. So we have gone almost like up to probably 300 microns depth, and during the surgery you can always assess the residual bed. That is how you can know how much depth you have gone. We need not do a deep lamellar keratoplasty. It is almost like a little bit of anterior lamellar keratoplasty going up to 2/3 of the corneal stroma. So once you take it out, the infective part, because you know roughly about 192 microns it has gone penetrated into the stroma, so you can have a guarded knife also, 300 microns guarded knife, to make a round cut, and then you can go ahead, which will be more precise. So after this, then you can replace your optical, you can replace any therapeutic grade button, and you can always check out this Desper's membrane. You can stain it for your better look, and you need not stain it also. You can just peel it like that. But you take a clear cornea a little bit, so that the post-op edema, it won't be there. This is how we have got a good more than 1 millimeter rim from the center of the ulcer all around. You have taken about 8 millimeter of graft, and then is stitched on the residual stromal bed. You can give also the so you can go underneath and just give a voriconazole wash little bit and you can leave it also, or you can leave it like that also. So this is how the integrity of the globe is secured with a better visual outcome. So you can see that the post-op, immediate post-op, about 7 days, and this is about 2-3 months. You can see the amount of corneal residual bed it is left out. So even if you give the full thickness cornea here, it is almost like this will be almost like 1/5. That means about 100 to 150 microns has been cornea has already left, and this didn't show any recurrence. So the therapeutic outcomes of TDALC has been compared, a study long back by the SNSC group by also Arundhati and Anand Partha, and they have, of course, they have taken a lot of bacterial keratitis as their marker, and they felt bacterial keratitis the TDALC was better. For similar studies are done for lamellar fungal keratitis in Chinese group, and they have found out the recurrence of corneal ulcer is seen in aspergillus, steroid, and the cases which are taken pre-op with hypopyon and endothelial plaque. So they also added one observation to that fungal hyphae pattern is more important for the recurrence. So where they have found out that hyphae who grown horizontally, like fusarium hyphae in the corneal stroma, has less recurrence than the aspergillus who vertically grown into the corneal stroma. So however well surgery were done, you should be lucky enough to get rid of this TPK. TPK primary, as I said, the primary goal is to get rid of the infection. Next secondary goal will be then sight. Sight is not important. So you can see whatever best you have done, many cases we have seen the recurrences, and many cases although there is no recurrences, final outcome will be 360 vascularization with failed graft and bullous keratopathy, secondary glaucoma. These are all the miseries of the TPKs. All that is seen in the or placed in the paper or pen. It doesn't happen in the normal way. I think the presentation time, the accessibility of the patient to the tertiary center for frequent visit and treatment, and correct timely surgical intervention can probably prevent this type of consequences which is inevitable in the late stage of TPK. Thank you for your kind attention. So the take-home message for this is corneal opacity represents fifth leading cause, and the several studies have highlighted the emerging trends of antimicrobial resistance in ocular infections. Early TPK for infectious keratitis will have a better outcome. TDALC should be considered a surgical option for infective keratitis, and TDALC should be promising, gives a promising results, but it has got its own challenges, and like correct diagnosis of the depth of the organisms, and for that you should have a confocal microscope, and surgical expertise to do a DALC also is needed. Thank you again. These are my references.